I think the growing crisis in our healthcare system is rapidly becoming probably the single most pressing domestic challenge we face today. Not just because of the growing number of people who lack timely access to either medical care, but also because of the implications of the opportunity costs implied with spending an ever-growing portion of our budget on this one sector alone. It also poses, I think, the most immediate threat to the fiscal stability of the United States. Last year, Congress voted to raise the statutory debt ceiling to accommodate a $10 trillion national debt. Do you have any idea how much $1 trillion is? I mean, it's a number so staggering, it's impossible to wrap your mind around it without a frame of reference. So I'm going to give you a little pinning exercise you can do when you go home tonight. 1 million seconds ago was last week. 1 billion seconds ago, Nixon was leaving the White House. 1 trillion seconds ago was 30,000 BC. We've got a $9.2 trillion national debt, and it's escalating as the population ages. And while Congress is worried about Social Security, the real problem is Medicare. Social Security is about a $7 or $8 trillion problem. But by comparison, when the baby boom generation fully reaches the age of 65, which starts 3 years from now, the projected unfunded entitlement of Medicare exceeds $70 trillion. And we're paying for that by selling securities to Japan and China and other countries that are still willing to purchase them. Not only giving huge leverage to some of our major international competitors, who at some point may refuse to underwrite U.S. deficit spending, but casting a dark cloud of debt over the future of our children and grandchildren. Indeed, former Federal Reserve Chairman Alan Greenspan touched on this very issue in an interview last year in Fortune magazine, in which he said, referring to the pending crisis in Medicare, no politician wants to confront this, and this is a very sad event because what's at stake here is the fiscal stability of the American government. To solve this crisis, we need two things. First, we need a shared vision, a set of agreed-upon objectives that captures the desired purpose of the U.S. healthcare system. And second, we need an accurate diagnosis of the underlying problems that we're trying to fix in the current system. So let's start with the objectives, by reminding ourselves that the purpose of the healthcare system is to produce health, not simply to finance and deliver healthcare. In other words, healthcare is a means to an end, not an end in itself. It has no intrinsic value outside its relationship to health except as an economic commodity. And that is a vital point that has to be reflected in our system objectives. Now, I think the work of the Institute for Healthcare Improvement has captured this concept and offers us a solid foundation on which a new system can be built. And this is the so-called triple aim. First, to improve the health of the defined population. Second, to reduce per capita cost. And third, to improve the patient experience in terms of clinical outcomes, in terms of patient safety, in terms of patient satisfaction. Now, I don't think many people would disagree with those broad system objectives. The problem is that you cannot accomplish them by operating within the context and constraints of the current system, because both its financing component and its delivery component are deeply structurally flawed. So let's start with the financing component, which was not developed around a broad commitment to access, but rather around something called categorical eligibility. Now, what does that mean? It means that in the United States, in order to get publicly financed health care, as opposed to publicly financed education or public safety services, you have to fit into a category. And those categories were created through 3 separate unrelated acts of Congress in the middle of the last century. The first was in 1954, when Congress granted employers the ability to deduct from their taxable income the cost of their contribution to their employees' health care, which is a publicly subsidized tax benefit for employer-sponsored coverage. The other 2 acts, completely unrelated to the first, were the enactment of Medicare and Medicaid 11 years later in 1965. Medicare is a program for those in the category over the age of 65. It's an entitlement program beginning at age 65, regardless of the income of the retiree, but is financed primarily by taxes paid by people who are still working. Currently, 9% of all federal income taxes go to the Medicare program. A number that's going to increase to 19% by 2015 and 32% by 2025. So it's the cost of the Medicare program as the baby boom generation begins to become eligible that's creating the fiscal crisis that our nation faces. Now, Medicaid was created again in '65 to improve financial access for some but not all poor people. To be eligible for Medicaid, being poor isn't enough. You also have to fit into a category. So if you don't fit into a category, if, for example, you're a poor man or a poor woman who isn't pregnant without kids, you're not eligible for Medicaid no matter how deeply impoverished you might be. The point is that all 3 of these acts made great sense at the time they were put into place. And they all grant a public subsidy, not to everyone, but only to certain categories of citizens. The problem is that the economic and demographic environment in which these programs operate has changed dramatically in the intervening 50 years, but the programs haven't. continuing to reflect the realities of the past, not the challenges of the future. Now, unfortunately, these structures are protected within the political process by powerful economic interests deeply invested in the status quo. But as we've just seen, clinging to this outdated structure increasingly depends on the relentless and unsustainable consumption of resources that rightly belong to future generations. Now, this eligibility and financing structure has two major third-party payers. On the public side, we have Medicare and Medicaid. On the private side, we have employment-based coverage. But because this was developed around categories rather than a commitment to access, there's a growing gap between the public and private arms of the system. And in that gap are people who don't fit into a category. They're not 65, so they're not eligible for Medicare. They don't meet the income or categorical requirements for the Medicaid program. They don't work for an employer who offers coverage, and they can't afford a policy in the private individual market. We have almost 50 million people in that gap today. Now, the gap exists again because we backed into a system where eligibility is based on category, and thus the United States has avoided answering the most basic question in the healthcare debate that's been answered by almost every other industrialized nation in the world. And the question is simply this: in America, who has the responsibility to pay for the healthcare needs of people who can't do it themselves? And because we've never answered that question as an explicit matter of public policy, by default, we let the economic market answer the question for us. But markets, of course, are designed to make a profit, not to foster social responsibility. So it shouldn't come as a great surprise that people don't go out and compete for folks who won't pay them. As a consequence, people who are in the gap, or who can't when they get sick enough, when they can't find a primary care doc to see them in the community, they go to the emergency room where federal laws require that they be seen and treated. And the uncompensated costs are just shifted back to the third-party payers through incremental increases in their premiums or their bills. Now, the third-party payers, unfortunately, simply shift the cost back on individuals. States do it by changing the income eligibility standards to reduce the number of people covered by Medicaid. Businesses do it by dropping coverage altogether or by increasing co-payments and deductibles that shift out-of-pocket expenses to employees who at some point can no longer afford the cost of care. And both of those strategies simply drive more people back into the coverage gap, repeating the cycle. Now, I submit to you that this arrangement makes no sense as a business model. It makes no sense as a social policy. And in fact, it costs us far more as a society, both in human and in economic terms, to leave a growing number of our people without the ability to access care in a timely manner than it would be to explicitly adopt a policy of universal access on the front end. Because today, we have a de facto policy that says we're not willing to pay pennies to manage your blood pressure in the community. We'll pay tens of thousands of dollars to treat your stroke once you have it. It's a policy that says we won't ensure that all of our women have adequate prenatal care, but we're happy to pay the cost of resuscitating a 500-gram infant in a neonatal intensive care unit and then shifting that cost to the shrinking employer community that's still willing to do that. And that shouldn't be acceptable to any of us. So the foundational step we have to take in the financing component of our system is to explicitly answer the question, who has the responsibility to pay for the health care of Americans who can't afford to do it themselves? And inevitably, that responsibility will fall to the public sector. Just as it is a public sector responsibility to ensure that all our children have access to at least a primary and secondary education, just as it is a public sector responsibility to finance police protection, fire protection, and maintain the national defense, it is a public responsibility to ensure that all Americans have access to some effective level of health care. But, and this is very important, it can't be an open-ended responsibility because the fact is public resources are limited. If they weren't limited, we wouldn't have a $9.2 trillion national debt or an exploding budget deficit in 2000. And because public resources are finite, and because we can't spend all of our tax dollars on health care at the exclusion of education and economic development and other priorities, it follows that the public resources available for health care are also finite. In other words, the floor, or the basic level of care to which all of our citizens will have access, is by definition what we are willing to pay for with public resources. Now, this concept of a floor is very important because in the current national debate about universal coverage, no one seems to want to answer the question, coverage for what? Now, obviously, we don't have the ability as a society to pay for everything for everyone who might benefit from it. Clearly, there are limits. And it is within this floor that we have to come to terms with our limits as a society.